Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Today we're continuing our studies of the 2019 ICD-10-CM coding guidelines, and we are down to 1B18. Guys, this one is going to be a three-part discussion video. I tried to do it all in one and it is just too long. So I'm going to split it up, and in splitting it up, it's going to take 3 different videos. So bear with me and follow along with me as I get these 3 parts done. All right, we're going to start first with reading the guideline. Follow along with me. And it says, use of signs, symptoms, unspecified codes. Signs, symptoms, and unspecified codes have acceptable, even necessary uses. While specific diagnosis codes should be reported when they are supported by the available medical record documentation and clinical knowledge of the patient's health condition, there are instances when signs, symptoms, or unspecified codes are the best choices for accurately reflecting the healthcare encounter. Each healthcare encounter should be coded to the level of certainty known for that encounter. If a definitive diagnosis has not been established by the end of the encounter, it is appropriate to report codes for signs and/or symptoms in lieu of a definitive diagnosis. When sufficient clinical information isn't known or available about a particular health condition to assign a more specific code, it is acceptable to report the appropriate unspecified code. And it says, for example, it gave you as if you were coding pneumonia. The diagnosis of pneumonia has been determined but not a specific type. Then all you can code is the unspecified pneumonia. Moving right along. Unspecified codes should be reported when they are the codes that most accurately reflect what is known about the patient's condition at the time of that particular encounter. It would be inappropriate to select a specific code that is not supported by the medical record documentation or conduct medically unnecessary diagnostic testing in order to determine a more specific code. All right, Codemaster, what are you saying? Think about it, the healthcare setting that you're in. Physician's office, emergency room, hospital, day surgery. Think about the setting that you're in and when your patient comes in. And what can be done while you're there. I think of a physician's office. In a physician's office, you're in and out in 15, 20 minutes. Other than the wait room. When you go back in the room with the patient, you see the physician face to face, 15, 20 minutes. Is that better? All right, so think about the signs and the symptoms. As a patient, I go in with symptoms. What are symptoms? I told you in a previous video. A symptom to the patient is a sign to the physician. So if I go in and tell my physician I'm experiencing headache, shortness of breath, chest pains, my physician is listening to my symptoms, and ding, 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 these are signs to him of a disease process that may be going on. So, what are the rules when it comes to assigning signs and symptoms? The first rule is, if the patient is in an inpatient setting, now we're in a hospital, we're not at the physician's office, we're in the hospital, a diagnosis described as possible or probable and so on at the time of discharge is considered to be an established diagnosis. For example, a patient is admitted with abdominal pain. The physician's diagnostic statement is abdominal pain probably due to acute gastritis. Only the code for the acute gastritis is assigned because abdominal pain is an integral part of the disease process. Make sense? What are you saying? I'm saying that if the sign or symptom is considered to be a part of the disease process, then once you capture the disease process, you've got the sign or symptom. You don't need it. Okay? Words such as possible and probable are not considered to be established for an outpatient setting. Now we're in an outpatient setting. If there is not an established diagnosis, only the symptom or signs are available to the highest level of specificity or certainty, and that's the only one that can be assigned on an outpatient basis. So think about, in this video, I just want you to think about the setting that you're in. If it's a physician's office, if the physician says, you can't code probable or suspected on an outpatient basis, but you can on an inpatient basis, because it's understood as on an inpatient basis, the physician has time to run tests, labs, x-rays, etc., to try to figure out what's going on. And sometimes the disease process just isn't ready to show itself, so all you can code are signs or symptoms or unspecified. But on an outpatient basis, when you go to a physician's office, a lot of times he doesn't have the results of your lab or your x-rays immediately right then in that 15 to 20 minute visit that you're there. So the only thing that he can diagnose you with is your signs or your symptoms. So in this video, I just want you guys to think about the different settings, outpatient versus inpatient, what actually goes on during those visits, to help you to understand why a physician can only diagnose so much on an outpatient, and then on an inpatient, when he should have a definitive diagnosis, sometimes he doesn't, and all you have are a sign or a symptom to code. Therefore, when he says it was probably or suspected, then a lot of times that's what he's going to end up treating you for, and you can code probable or suspected or questionable on an inpatient, whereas on an outpatient basis you can't. All right, guys, think about that. When we come back in my video number 2, I'm going to answer the question, when can the signs or symptom be correctly designated as the principal diagnoses? So stay tuned for part 2 of this video on signs, symptoms, and unspecified condition. All right, guys, thanks. I'll see you in the next one.